All right. Thank you so much, Mark. This is a real honor and a privilege for me to be here. As Mark said, I grew up in a smaller sized town in southwest Oklahoma, about 20,000 people, and my dad was a family doc. And so coming out to Cortez and getting to go out into the parts of the rural America is like going back home a little bit for me now. As I talked earlier, this is way, way, way more beautiful than what Altus, Oklahoma was. The other thing you should know is that, as Mark alluded to, you have the inside scoop of the stories of how I ended up where I ended up. There's a little that's not in the bio, and I did tell you could make up what you introduced me with. I did tell him it was fine. So because this is the true part of how I became where I am in these aspects is. So he said, I grew up in Oklahoma. I wanted to get away, and I grew up a big sports fan, so I went to Notre Dame, and then I came back to Oklahoma. So you can imagine sports is big. And I met my wife, who is this infectious disease pharmacist, who actually taught me my antibiotics as a third-year medical student because she was doing a residency in antibiotic stewardship and kinetics, so you can imagine what that was like. But she was from Nebraska. I'm from Oklahoma, man. You just don't... Yeah, exactly, right? So you can't just go to Nebraska willingly without some kind of deal in place, right? So the deal was I would go to Nebraska if I got in, and then I could go wherever I wanted for fellowship. And so lo and behold, the Country Bumpkins headed out to Philly and spent 3 years there, and then we're back in the Midwest. And then just recently moved to St. Louis, which has been a great opportunity. And really, my passion has been antimicrobial stewardship. We started a program there in Kansas City in 2008. And then I've kind of, over time, got to meet wonderful people like Mark and hear about just the amazing, amazing work that's being done out here in rural America around a topic that I think is not quite easy. I was just talking about this to a group of family practice physicians in Springfield, Illinois, and this is a tough topic, and so I appreciate everything that you guys are doing. So what am I going to talk about? Well, I'm going to go through kind of some history, talk about hopefully some things that'll be helpful for you guys in thinking about how we manage some of our antibiotics with certain conditions. I will make sure later on to Mark that we have kind of a document that I'm going to show a little bit about that's been revised for you all to use. It is based on some of our data in St. Louis, but please, I'll have that to you. And then we'll talk about some stewardship in the outpatient setting. And again, it'll be focused really toward pediatrics, so thinking about the pediatric side of things. Okay, so here's I just kind of went through, and so let's start with a story. And this is what you're going to learn about me. I am from Oklahoma, and therefore I tell stories. And this story starts actually from a medical paper that was given to me by one of my colleagues at St. Louis Children's, and it's a paper regarding a fourth-year medical student, and it's him chronicling a disease, and then somebody finishing that to make it a medical paper. And I think it's important to what we're talking about today, just to kind of set back what it was like. So the story starts in 1921. This medical student was a 13-year-old and develops choreiform movements. So even in this day and age, if we say a 13-year-old walks into your office with the choreiform movements, what's the first thing you think of? Yeah, strep throat, right? Or rheumatic fever, right? This was a group-based strep disease. This is rheumatic fever. In 1921, there's no question, right, that this is rheumatic fever because they saw it. And they saw it a lot, right? Because we couldn't treat strep throat, right? Because we didn't have the antibiotics to treat it at the time. So 1931, as a fourth-year Harvard medical student, he sees petechiae on his wrists. Right? And he turns to his sister-in-law and says, I shall be dead in 6 months. Why did he say that? What does he think he has at that moment in time? Anybody? Petechiae? Endocarditis, right? He's worried about endocarditis. Now, he goes to a number of physicians at the time and says, don't worry. This is probably just a rheumatic flare. Right? This is what we've seen. This is what happens. Now, his initial rheumatic disease, they knew that he had both aortic and mitral valve involvement, obviously based on these amazing clinicians that could use a stethoscope and tell you that for sure. And so what happens next? Well, someone finally got a blood culture, and it was positive for strep viridans. And he says, I could always find a loophole in the evidence here and there, but now I was confronted with a dictum ultimatum from which there was no escape. Right? That was the moment he knew he had endocarditis, and he died 3 months later after having a stroke, and then dying after that. That's 1921. Not 1 month ago, as a pediatric infectious disease physician in a quaternary care, expensive, crazy, all the kinds of patients we can care for, lung transplants, heart transplants, bone marrow transplants, the sickest of the sick. I saw a baby that was born with a single ventricle that had gone through 2 repairs and now had endocarditis, and not a single one of us worried that that baby was going to die because we had antibiotics and we knew we could treat them. That's what's changed from a common illness leading to rheumatic fever to leading to an endocarditis and death to now we can save the sickest of the sick because we have therapeutic agents that allow for that. So where do we start really with antibiotics? Right? We often think of penicillin, but it really started with sulfa by Dr. Gerhard Domack, who was actually doing studies around medicinal dyes. And he noted that these dyes probably had these antimicrobial properties, so they used it in a 10-month-old with Staph aureus bacteremia in 1933. So in 1933, if you had Staph aureus bacteremia in a 10-month-old and you didn't give them anything, you know what happens. They die. Right? So now you give this sulfa drug, and wow, this baby survived. As irony would have it, this medicine was used on his own daughter who had cellulitis of the arm. And as you can imagine, if you had cellulitis of the arm in 1932 or before 1933, you had debridement, possibly amputation for your treatment courses, right? So can you imagine not being able to treat some of these common conditions, and now all of a sudden people survived? People did really, really well, and you'd have to do some of these really heroic measures to save them. So there's a quote that came from a book, and it says this, and I'll read it because I think it just takes us back to really what it must have felt like. He says, "For most of the infectious diseases on the wards of Boston City Hospital in 1937, there was nothing that could be done beyond bed rest and good nursing care. Then came the explosive news of sulfanilamide and the start of the real revolution in medicine." Right? None of us can even imagine what that was like, really. But this is what it was. It was a revolution. It changed everything. So here's our next test question, right? Wrong one. Who can name this person? Who's that? Anybody? Petri dish at the beginning on the slide? I know somebody can say it. Anybody? Alexander Fleming, right? So Alexander Fleming discovers penicillin, that initial slide at the beginning where you had that lawn of bacteria and that penicillium mold. And then, but you know what? Fleming actually didn't think you could use penicillin. He thought, we're never going to be able to purify this. We're never going to be able to give it to a human safely. So along comes this gentleman. This guy's named Howard Florey. And to demonstrate how big of a nerd I am at this topic, there's a book all about him. The Mold in Dr. Florey's Coat. And it talks about this history of him realizing that he could purify this medication and then use the medication. Now, the title has a historical significance. The title is in the time of World War II. He was in Oxford in England, and obviously the Germans were bombing England, and so the title refers to the fact he could take one of these penicillium spores, put it in his coat, and then come to the United States. Now, the United States had a big part of this story in the sense that he did come to the United States because we had a number of pharmaceutical companies, and that's where the mass production occurred. Now, the first actual use of penicillin, I think, in everything I've read, goes back to this officer, Albert Alexander, who had an awful infection of his face, lost his left eye, developed horrible pneumonia. They says, well, we have this medicine. We have penicillin. Why don't we try it? We don't have a lot of it, but let's try it. So they didn't know the dose. They didn't know how often to give it. So they give some medicine. He gets better. Again, they didn't have a lot. So they actually purified some from his urine, gave it back to him till they had no more. They exhausted everything. And while he did get better, he recrudesced with pneumonia and then passed away. Now, this was huge and super exciting for everybody. But the thinking was after this, we weren't going to use it until we had enough supply. And we know the next part of the story, right? For us, penicillin has become an agent we have used, maybe not as much as they did initially. And I think Alexander Fleming, while I kind of talked about him not maybe realizing the potential impact up front, he did realize what could happen next and what we are faced with today. And that's this following quote that he stated in New York Times in 1945. He said, "The greatest possibility of evil in self-medication is the use of too small doses so that instead of clearing up infection, the microbes are educated to resist penicillin and a host of penicillin-fast organisms is bred out, which can be passed to other individuals and from them to others until they reach someone who gets a septicemia or pneumonia, which penicillin cannot save." Now, I mean, just replace penicillin in this paragraph now, right? I mean, I'm sure many of you in this room could say, hey, I've had a ceftriaxone that wouldn't work. Maybe some of you even seen where they haven't had a carbapenem like meropenem work. In 2009, when I was an attending again on the Pediatric Infectious Disease Service, I was rounding in the NICU, seeing a baby that was suffering from Pseudomonas bacteremia from a central line. Now, that's this was an X 24-weeker. I mean, again, this is the amazingness of what medicine has become, right? A 24-weeker in 2009 has probably a really decent chance of going on to have a fruitful and a fruitful life and even thrive. And this child got Pseudomonas bacteremia. We treated with cefepime, got better, but came back. Got it again. The line was removed. Treated with carbapenem, meropenem, because it was resistant to cefepime. Got better. Pseudomonas comes back again. Now it's resistant to meropenem. We give colistin, and then the baby died. I mean, that was, 7 years ago. Now, that hasn't happened a lot, but it's not the last time that I've seen a patient die of a resistant infection that I think you can obviously say that was the cause. And so this is what that topic is. I mean, this is what we're seeing, and we're only seeing more and more of it. All right, so here's the next thing, right? So you're like, well, Jason, you work in these, this tertiary, all these crazy patients. Are we going to see this? Does this matter? Maybe we have enough antibiotics. And we're saying, well, this figure kind of gets at this, right? It says, okay, we have antibiotic deployment, we have antibiotic resistance, top and bottom. And there's two real important points of this figure. One is, when you see an antibiotic deployed, you see antibiotic resistance occur. Now, someone pointed out last week that, hey, ciprofloxacin's not in here, but we know ciprofloxacin probably came in here, and resistance came soon after. The second important point is this. There's a ginormous gap in antibiotic development or deployment. And that is worrisome, right? Because if we are going to get resistance, unfortunately, right? These bugs are going to be changing. There's way more of them than us, and they evolve quickly. So we are going to see that. So we're going to need new drugs, and if we have these sorts of gaps, we're going to get further and further behind the 8 ball, so to speak. Now, why is that a gap? Well, it's the economics of the world, right? It's the economics of the United States. These drugs, these antibiotics, are finite in their duration. They're not a Lipitor. They're not a diabetes medication that someone's going to use forever. And then you have people like me running around saying, hey, just stop using that. Use a different dose. Hey, I don't think you need it. Right? There's other pressures that are saying, well, why would a drug company go into that business? There's some new data that suggests, I haven't seen where they've published this, but there's some experts suggest that if you wanted to make a new antibiotic today, you say, okay, I have this great idea. I think this will work. Your net present value after going through all the triumphs and failures and clinical trials and getting to where you could sell it, your net present value today is a negative $50 million. So are you going to make that investment? Heck no. Why would you do that? So, again, there's a lot of pressures when it comes to new antibiotics. So, all right, so what? All right, so maybe, but I'm not saying we don't need antibiotics, right? This isn't a, surgical site infection or central line infections where the answer to this is zero, right? We want zero of those, and we feel like now maybe we can get to preventing all of them. Now, I don't know if that's true, but maybe we can. The use of antibiotics, like I said at the beginning, has revolutionized medicine. We are going to have to use them. So if we look at data about, well, how often are we actually appropriately use them? In pediatrics, not so often, right? I mean, we're inappropriate about a third of the time if we look at vancomycin. If we look at vancomycin and cefepime, now this is inpatient use of antibiotics. They're at 11 and 6%, so much better. If we look at our NICUs, it's about 1 out of 4 of our antibiotic days. If you look at the adult world, they'll suggest 30 to 50% are inappropriate. And I'll get to some outpatient data a little bit later in the talk. But again, there's a lot of inappropriate use. And that inappropriate use, as we know, just helps us see more resistance. And the one bug that worries me and scares me to death is the carbapenem-resistant Enterobacteriaceae. And those Enterobacteriaceae, right, are the E. coli's, the Klebsiellas, the things that cause urinary tract infections, right? Those common illnesses that we see, that you all definitely see most days. And while the map says that Idaho and Maine have no CRE, I don't believe them. There's no doubt that this is everywhere. And the CDC has made this an effort since 2012 to see what we can do to try to prevent or to limit the amount of CRE we're seeing. So then the next thing is, well, does it matter, right? I mean, does these resistant bugs, does it impact us clinically or our patients clinically? Well, we have new data that shows that this was published in the fall of 2013, that annually 23,000 Americans die. Another 2 million are infected by antibiotic-resistant infections. And then another 250,000 suffer from C. difficile infection, which, as we know, is a side effect or an adverse event from using antibiotics, of which the all-cause mortality in this paper suggested 19,000 die from C. diff infections. A newer paper from New England Journal of Medicine suggests it's up to 29,000. Regardless, these cause significant burdens on our patients. So C. diff. You know, in pediatrics, if we want to think about it from a pediatric perspective, we see most of our C. diff in the outpatient setting. You guys know this better than I, right? The major risk factors are antibiotic exposure, being exposed to protein pump inhibitors in the elderly. If in children they get hospital onset C. diff, their odds ratio of death is 6.7. And I kind of mentioned the deaths. Again, this is one of those things that you guys are way more familiar with than I am because you see this. But that is a consequence of using antibiotics. So the other piece that we don't talk enough about, right? You guys are probably thrown at all the time, oh, the resistance, I know, the resistance. The other piece of this is the adverse events. And they aren't trivial. So this is a paper, this is an older paper now, but I think most of us still consider this what we're experiencing is that there's an estimated 140,000 visits for antibiotic adverse events in our emergency departments, which makes up about 20% of the ED visits. These illnesses are simple like nausea, diarrhea, vomiting. You know, people go to the emergency department for some, what we would consider minor things, but they're worried, right? And these are associated with these drugs. Not surprisingly, half are due to penicillins and cephalosporins, being those are our most common drugs we prescribe. And also not surprising for you all, that the highest rates would be associated with clindamycin and sulfonamides, or like the Bactrums of the world. So with that, right, so here's the scare technique. Well, he throws all this out. What can we do, right? What are the solutions? How can we do better? Well, I could talk an hour on each of these, and you guys will all trickle out over time, but so I'll be quick. One we talked about, right? We have to have new antimicrobial development, and there are regulatory mechanisms that are trying to be put in place to allow for that research and development and to stimulate that because we are going to need them. We need stewardship programs, both inpatient, outpatient. How do we work? How do we make sure for that even the children that they have these stewardship programs as well, or the stewardship interventions? Better diagnostics. I mean, I can't tell you, obviously, those of you and that you're working in the outpatient setting and you're kind of in this conundrum of, is that virus, is that bacteria? I have someone that's maybe, I feel like they're demanding the antibiotic, and I'm standing on a weak leg, right? I'm on a 3-leg chair, and I don't feel as confident. Better diagnostics that are cost effective could be a potential solution. This is one that I talk about a lot. Know the best lengths of therapy. So, in children, If you have a child with otitis media, how long do you treat them? 7 days? Anybody else? How many do 10 days? 10 days, right? So if you go to like guidelines, you'll see 10 days. You might see ceftriaxone, right? Some injections for 3 days. The reality of it is there's not a lot of data on what is the best length of therapy. If we look at community-acquired pneumonia, something that I've looked at a number of times, our national guideline from the infectious disease side of America that's pediatric-based says 10 days. And if you read the sentence after, it says, based on expert opinion, though there are some data that possibly suggest you could go shorter. Again, we don't have the data. I would suggest that, our adult populations, those of you who care for adults with community-acquired pneumonia, you can treat them for 5 days. You have data that shows that that's safe and effective. I don't think that would be much different for a kid. So again, that's where we have to get more data. Now there are papers coming out soon. There's a urinary tract infection paper study that's comparing 10 versus 5 days for outpatient UTIs in children. There's an otitis media study that's ongoing that should come out soon that's also comparing 5 versus 10 days. And then there's a new community-acquired pneumonia study that's just launching that, again, is going to compare 10 versus 5 days. Again, all outpatient studies that we will see soon. Okay, so an infectious disease doctor can't stand in front of an audience without saying we got to reduce hospital-acquired infections, which means we need to wash our hands better, essentially, right? That's one of the major strategies. The other reason an infectious disease doctor can't stand in front of an audience without saying we have to vaccinate better. And that's in all populations, right? Influenza season right now, we need to be vaccinating. Our pneumococcal vaccination for both the young as well as the elderly. The pneumococcal vaccination, especially the new Prevnar 13, has demonstrated an impact on resistance. We are not seeing the invasive pneumococcal disease with the resistant strep pneumos that we saw 4 or 5 years ago prior to the introduction of pneumococcal conjugate 13. Now, could that change? Of course. We saw that after Prevnar 7. But I think this is one of those interventions where you can show that it does impact resistance. And finally, and again, I could go for hours on this one, the antimicrobial use in agriculture. Yesterday I was actually in Washington, D.C., where we spent the day kind of talking about what we should be doing next around that issue. And it is in the National Action Plan, but not as probably as specific as it is for the human medicine side. But my point here that I would say is that this, as well as all this, is a societal approach. We're going to have to all do it together. It can't just be one side saying, "Oh, we're doing it, you're not." We are going to have to work together. All right, so I know you guys have been real talkative, so let's see if I can draw this one out of you. All right, so here's a case, right? So 17-month-old presents with fever, almost 39, rhinorrhea, cough for 3 days. The vital signs are stable. They're tachypnic. I will say they're tachypnic, and their oxygen saturation is below 90% at 89%. You have exam with focal crackles in the right lower lung. What do you guys do next? In this part of the world, in this part of the country, what's the next thing you'll do? How many get an x-ray? Okay. How many are going to admit the child? No? So what antibiotic are you going to use? So Augmentin? How many are going to do amoxicillin? Okay. Of those, let's say you're going to admit them. What are you going to treat if you admit them? Ceftriaxone, anybody else? Anybody use something different than ceftriaxone on the admitted patient? Okay. Ampicillin, I heard ampicillin. All right, so this is good, right? So there's two different focuses of this, right? All right, so this would be our routine community-acquired pneumonia. If you say you think, hey, I'm not going to admit them, no, you don't get a chest x-ray and you send them home, the recommendations would be amoxicillin. We're treating streptococcus pneumonia disease. On the inpatient side, you get an x-ray, you see there's no big pleural effusion or what you think is a complicated pneumonia. You know they're vaccinated. Ampicillin is what the national guidelines are recommending. So we looked at this and we said, hey, in our hospital in Kansas City, we thought, well, why don't let's create a guideline and do this work. And this is to say, I think guidelines can work in these different situations. So I found this resident at the time, Ross Newman, who would review 2,000 charts. What Mark doesn't realize is how bad I am to work with. And he evaluated these, and we had 1,000 were included in the study, and this is a pre-post after a guideline was implemented. They looked like pneumonia, right? They had fever. A third of them had received antibiotics before coming into the hospital. And even then, we said, give them ampicillin as long as it was uncomplicated pneumonia. They had the oscillatory findings you would expect. Now, we had 3 main recommendations for this guideline. 1, do ampicillin. 2, get a blood culture. And 3, treat them for 7 days. All right, so I'm going to show, I tell you that for 2 reasons. You can see before and after the guideline, they said, no way am I doing that. And you can see they said, no way we're going to do the length of therapy either. So that data was not convincing to them at all. And we've talked about that later on. That wasn't the reason I left. But this was the other data. This is where it was interesting to see that clinicians felt comfortable switching their empiric choice. So in this figure, you have ceftriaxone in the black. You have ampicillin in the gray. And we implemented our stewardship program, and then we did the guideline, and it just flipped. People had no problem switching from ceftriaxone to ampicillin. And I've seen this in other conditions that's comfortable. Now, the length of therapy, not comfortable. Blood culture, not comfortable. But you know what I didn't realize was the impact this would have on outpatient treatment, right? Because you guys know this better than I, right? Their lengths of stay for a kid with pneumonia, a couple days, right? They get better pretty quick once they get started, and as long as it's not a virus, right? And what we saw was, because we switched to ampicillin, the amoxicillin here in the diamond with the black just went sky high. And we saw that our augmentin and our ceftonir, which I think ceftonir is a terrible pneumococcus drug if you're treating strep pneumo, went down real low. And so I think this was the impact. Now, everyone in the room probably is going, well, did you have more failures? Did you get more people come back? Did they have more complications? We did not. It was equal on both sides before and after. There was no increase of what we called failures, meaning we had to broaden our therapy, or those that went on to a complicated pneumonia requiring chest tubes, the same numbers before and after, and in those groups of the ceftriaxone and ampicillin group. So this was something I think is easy to do, quote unquote easy to do. It's something that I think is effective and I think has an impact later. Yes?
So that doesn't matter how many doses previously they received of amoxicillin before you treat them?
Yeah, so even today, this is one that people struggle with. It's like, well, they've been on amoxicillin. So even then, switching them to putting on the ampicillin as they've came in, it's been fine. And I've done this in 3 settings now. So we're in fellowship in Philadelphia. That's how we manage them. In Kansas City, we did it this way. And now in St. Louis, we're doing the same thing. And that's a hard one to get over, right? Like, and then you're telling the parents, and they're like, really? And then seriously, we'll send them back out on amoxicillin. Now, there's a many rationales, right? Pneumonia, first and foremost, is hard to truly know if they have a bacterial process, right? The most common cause of pneumonia is still a virus, right? So there's a really good chance a lot of these are viruses. I can't predict which ones aren't. We just don't have the best diagnostics. Though I still think that for these, consolidated pneumonias with that strep pneumo, it probably still works, especially those that are fully immunized. Now, have we seen some that we've given the ampicillin and they progressed to complicated pneumonia? Absolutely. Do I think ceftriaxone would have made a difference? I don't think so, but I don't know for sure. But I think we haven't figured out what are the characteristics that says you're going to be one of the sicker children. So I still feel very comfortable with that recommendation. All right, so I thought I would just kind of go over a little bit about some of the common conditions that from the inpatient side as well as a little bit on the outpatient. Now, again, this is stuff you know, and so I'll go pretty quick through them, but something that I want you to just think about how I see it and how others are approaching it. You're going to have Lori Hicks come out and speak, who's just absolutely amazing. Who'll go further into the data that she's done, but I'll allow her to do some of the more in-depth there. So inpatient, we've talked about pneumonia, but as you know, skin and soft tissue infections are exceedingly common in this day and age, both in the outpatient and inpatient side. Head and neck infections, the retropharyngeal abscesses, the cervical adenitis, all of these things are very common. In the outpatient, it's upper respiratory tract infections, urinary tract infections, skin and soft tissue infections. I tell medical residents and medical students, I says, look, in pediatrics, you need to know really 4 bacteria, strep pneumo, group A strep, Staph aureus, and E. coli. you can say one of those almost every time and you're going to be pretty close to right. Right? I mean, that's what, so if you can know those, you're going to be right? Because that covers this for sure. So one of the things that we have done that I'll provide for Mark for you guys is a kind of an empiric guideline. And in this empiric guideline, we have put a diagnosis, the common pathogens, and then our preferred empiric choices. Now, this goes out to all of our prescribers at St. Louis Children's, as well as with our BJC healthcare system, which is made up of about 14 other hospitals. And we reviewed national guidelines. We looked at our antibiograms. We vetted this with our infectious diseases colleagues and our emergency department colleagues. I can tell you that our cellulitis went through 8 different versions from, should we empirically say clindamycin because of our MRSA rates when they didn't have non-purulent versus where we landed with starting with cefazolin or cephalexin or Keflex. As you can see with abscess, in our area we have about 50% of our isolates that hit our lab are MRSA. Again, this is all comers, whether you have a skin and soft tissue infection from a normal healthy person to a child with a tube that has a lot of otorrhea, that gets a lot of drops, that has that culture. So it's all comers. So we still feel we need to do clindamycin and Bactrim for these. If we look at like a periorbital cellulitis, this went through a lot of debate from should we just do a single agent like clindamycin to where we landed at amoxicillin clavulanate. The most common bugs still are group A strep, Staph aureus, and strep pneumo. But again, we give durations where we think we have information that will allow us to make a recommendation for that. But again, durations of therapy are hard. We don't see a lot of them. So what about outpatient? So I'm starting with maybe one of the hardest, the one that I probably hate the most, which is sinusitis. You've probably all aware the sinusitis story has jumped back and forth between give antibiotics, don't give antibiotics, when do I give antibiotics? Some just give it and say it's sinusitis. Some people probably come in and say, hey, my kid has sinusitis, give me an antibiotic. There are data, randomized controlled trials where they did use antibiotic versus placebo. And what I always say is this is the criteria that they came up with. And when you followed these criteria, that showed a difference with antibiotics, that you had quicker improvement. So those studies were done by Ellen Wald, who did them in Pittsburgh, and she's now in Wisconsin. And her lengths of treatment in these studies are 10 days. So just so you know, that's the length of treatment, though this last week I've heard someone says, well, I've done 2 to 3 weeks. And I can remember as a medical resident being told to do 3 weeks. Well, that's way you don't have to do that. No doubt. You don't have to do that. So what are these presentations? Well, the one is this persistent illness. Nasal discharge or daytime cough or both for greater than 10 days without improvement. Now, as you know, and you guys could tell me, right? You have a number of people says, oh, this hasn't been better. They say, oh, I've been coughing forever. My daughter just last week says she's been coughing for a month. I said, I haven't heard you cough at all. But again, right, there's all these anglings, and you guys probably hear it more than I do. But again, that's one that fits in a bucket, and as you can see, it's the most common. Worsening cough course, or that double sickening. I had runny nose cough. I got better. Now I'm much worse. More discharge, fever, headache. And so, again, this double sickening. And then the severe onset. Now, interestingly, purulent nasal discharge for greater than 3 consecutive days. Some will say, well, that's a lot of people, right? Flu season, that has to be a number. But I think in this day and age with our flu testing, you can somewhat distinguish this. This isn't, again, perfect, but I think this is the best we have. And we know you follow these criteria, you'll see improvement based on the trials. So watchful waiting. So this is a strategy. How many people actually utilize watchful waiting? Oh, I love this group. All right, so among you that do watchful waiting, do you do it for sinusitis? Yeah, some do it for...
Not to even schedule until they've been sick for 10 days.
Sweet, for the most part. Now, who does it for otitis media? Yeah, so a lot of folks do it for otitis media. And then for those that use watchful waiting for a prescription, what's your sense of how often they actually fill it?
Every time.
Oh, I got it every time. How about every time? Every time. Well, so some people, no, that's fair. I've heard some say, about a third will fill it to a 2/3. Usually the first one's. So I think it's intriguing. I don't know if we know the data well enough to know if that if there's,
We
yeah.
see adults, and it's probably 50%.
50%.
People are coming in saying, "Don't give me the antibiotics."
Oh, okay.
And they really are.
That's true.
So yeah, so and it's interesting. So yeah, you're finding that more and more. We're finding that people don't want the antibiotics, depending on where you are. So that's good. So this is one case, right? That persistent illness, right? You're kind of on the fence. You're like, are they really persistently ill? Maybe they did get better. This is another virus. I think this is one place you could use it. Do we have the great data that supports all of this? No. Now, what we do know is that the risk of complication, like brain abscess, is so low. It is not there in these cases. So, sorry about all the animation. I hate the animation. I think the key is, yeah, I know, right? We put this in. Not my slide, I think. Ugh. So, I think it's okay to observe these patients, but it's going to have to be a family agreement. And as you guys have, I appreciate you trying. I think that's still a strategy to utilize and to talk about, a lot of these are viral illnesses that will get better. But again, I think family input is going to be key still. And that's why I think from the outpatient world, getting our families on board, as it sounds like with your adults, that some say, hey, I don't really want this, is going to impact us and make prescribing better, for sure. And I'll show some data here in a little bit about that. All right, so another one, so otitis media, just really briefly, watchful waiting, I figured might have been used for otitis media because it's been talked about in the guidelines. And that's where if we categorize them into severity, so if we get them into severe and mild based on their fever and pain, there is recommendations based off of age group, whether it's unilateral or bilateral, when you could use observation or an antibiotic. Now, with that being said, it's RSV season. Have you guys seen RSV here? Not yet? Okay, so yeah, you've had two. So we have been seeing RSV, actually, we started seeing it in September. It was like this low level, but way more than we've ever seen this early on. As a matter of fact, one of my colleagues, Greg Storch, who's been doing this for 30 plus years, says most he's ever seen this early. And now we're seeing it. Now, why am I bringing up RSV? Well, you guys, again, know this better than I. You go see a patient with RSV, you look in their ears, and you're going to see you'll see crud in their ears. So last week in the hospital, I saw probably two or three patients that had RSV. We were doing our stewardship program, and we review all patients that get started on antibiotic, and had a number getting amoxicillin. Maybe one got ceftonir for otitis media in the hospital. I'm like, it's RSV. So I think it's all RSV. I would love them to use watchful waiting. Now, they fit into this age group, so I don't have as much leg to stand on based off this guidance, though I do believe that we probably could chalk it up to the RSV. And again, I think that's where we have to move to. But I would suggest trying to utilize these strategies, and maybe over time these parents will not fill them as we see. Now, other data suggests it's about, I think, a third won't prescribe or won't fill the prescription. All right, so another one. So strep throat. I know you guys see this all the time. This is a common thing. You're like, why would I bring this up about antibiotic stewardship, right? It's pretty simple. I give them penicillin or amoxicillin. Well, the stewardship piece here is actually the testing, right? It's when do you test, right? Because if you're going to test when someone comes in with that RSV-like illness, right? Runny nose, cough, like pure, like tons of runny nose, and you test them and it's positive, that's not group-based strep, man. That's a URI. You're probably just picking up the colonization. So this, in a stewardship perspective, is a stewardship of testing. That we really need to test those who have presence of fever and sore throat, age 3 or older. Now, if it's a 2-year-old that has a sibling in the house that has group-based strep pharyngitis, it's okay to test them. I don't want to say that's not a time to test. But you really need to have absence of viral syndrome. So that congestion, rhinorrhea, and then a consistent exam. And then that testing really matters and will show a true infection. Now, why do we treat it? The main reason to treat is to prevent the rheumatic fever. It's unclear whether it'll prevent some of the other complications of group A strep, such as the glomerulonephritis and others. So I think this is one of those settings where it's the testing. All right, we talked about pneumonia. I won't belabor this. You guys know this. We talked about this again. In the outpatient setting, you don't need an X-ray. It's been shown that the use of an X-ray in the outpatient setting actually drives more use of antibiotics than less, because we get that, perihilar atelectasis versus consolidation, and then we all feel we have to treat. So that's kind of the point there. I think the rapid influenzas and RSV in children, in adults are poor tests, right? The rapid influenza is a poor test in adults, but in children can be helpful. And again, I felt after I went through this, like, I got to say this. I just felt like I was in, again, most pneumonias are viruses in toddlers, and our antibiotics are not routinely needed. And again, strep pneumo. Again, and I think we're starting to see that atypical pneumonias, obviously in those children older than 5, and that's where azithromycin can be used. But that's where I would say that azithromycin can only be used, really, from others. All right, just some tables, and I think you guys I think they were going to send out the PowerPoint. I have a couple of tables in here about some recommendations. This is based off of some training that we're going to be doing for some practitioners with a study we're doing about some primary antibiotics and dosing. We still, to this day, recommend that high-dose amoxicillin for strep pneumonia disease. That hasn't changed despite our seeing the resistance has dropped to strep pneumoniae. I don't think the experts that work more closely with strep pneumoniae diseases feel that we should stop that. So that's still the recommendation for any streptococcus pneumonia type diseases like otitis, pneumonia, and sinusitis. But the one thing I'd point out, that amoxicillin can be used once a day for group A strep, and probably many of you are already doing that. So I'm not going to belabor. These are some of the alternatives. I'm more of a fan of amoxicillin clavulanate or augmentin for second line than the cephalosporins, so you can utilize the cephalosporins. And I'm guessing here ceftonir is still probably the most common, or Omnicef. It's frequently used because it tastes good and you don't have to give it that often. Okay, so the last one I like to, right, so I've kind of covered some of the big ones. The other one I want to talk about is urinary tract infections. So if you see a patient in your clinic or in the emergency setting, and you're like, that child has a UTI, because you know based off the UA, lots of pyuria, you're going to send the culture. What antibiotic do you start? Anybody?
I don't know.
For adults, yeah, what do you do in adults?
Yeah,
Macrobid, okay. Those who take care of kids, what do you guys do? Keflex? Bactrim, Keflex? I love it, okay. You do amoxicillin, great. So do you guys know your antibiogram for the area? Like what for this area in regards to the pediatrics and in the children and their UTIs? So it's an interesting thing, right? So because a lot of times with peds, it gets lumped with the adults. If you look in national data, Keflex, cephalexin, first-generation cephalosporins, E. coli susceptibility is probably 90 to 95% in all these national studies. So we have gone to say, hey, use Keflex. Now, that was a big change for us in St. Louis because we weren't even testing our E. coli's for first-generation cephalosporins. So we had to actually switch the lab to make this a useful tool for us. Our resistance rate, I asked the antibiogram piece because our resistance rate in the two places I've most recently been to both Bactrim and amoxicillin are in the order of resistance were between 30 and 50%. So suggesting, obviously if you're, go ahead.
But I thought there's not a risk of resistance if they haven't been treated with antibiotics. So that's why your first line is amoxicillin.
Yeah, so in these settings, these are a lot of times first time, and just because it's prevalent, you're still at risk because you're picking that up from the stools and likely just the contact with others. So that first time, at least from a UTI standpoint, at least for us, we're like, yeah, it's might not work. Now, some will say, well, hey, I can use amoxicillin, right, because it's going to overcome, it's going to be so high, concentrated, maybe that will treat it. But again, there's some concern that maybe it'll stick around more, so that's why we've kind of moved to the Keflex. And again, national data supports it. Every data I've looked at in different locales seems to support the use of first-generation cephalosporins, especially in children. Again, easy drug. We recommend doing it 3 times a day, and it makes it a lot simpler, I think. Okay. Any questions? Yes, Mark.
Some in adults, it sometimes says that cephalosporins need a longer duration. Do you see that in kiddos?
No, right now, again, the problem we have in kiddos is at 10 days, and it's based off of expert opinion. And so that's still what we're seeing. I think when we get this study out, hopefully soon, they've been doing the trial for about 5 years, we can do maybe 5 days on the outpatient side. And it's good to hear that people aren't going to third-generation cephalosporins, because I think our overuse of third-generation cephalosporins we know can drive resistance, probably greater than these other more narrow-spectrum drugs. Right. Yes, ma'am.
The one problem with your Catholics is that you have to dose it 3 times a day, and in a pediatric population, it's difficult with them attending school. So.
Yeah, no, I think it's one of these kind of, risk benefits of, hey, do you think that's going to be worthwhile, right? Because you can say, right, I'm just going to Septenier because it's twice a day. I'm still trying to push, I think 3 times is worth it in the end, but again, I think that's part of the things you have to weigh. I will tell you, we did something crazy when we first put this out. We had Q6 dosing, and we're like, oh my gosh, no one's going to do that, right? That's crazy. So we felt a little better, but it's a good point. All right, any other questions? All right, so stewardship. Now, you guys know this. You have Mark, and it sounds like you guys are doing stuff around stewardship. You've probably seen this definition. This is the definition that I always put up because I feel like it is what we're all after, right? We're going to pick the best drug at the best dose for the best duration because that's going to lead to the best outcome without the resistance, the greatest amount of resistance pressure, and also to decrease the amount of toxicity. So, again, it's what we're after and what we hope to accomplish. If we, real quick, on the inpatient side, you've probably seen these things. There's major strategies that are out there. One is this prior approval where we call somebody, and we do this in pediatrics where they'll call us if they want to use linezolid or if they want to use daptomycin. The one we're using more and more is this post-prescription review with feedback. I mentioned that before where I review, a pharmacist and myself review all our new antibiotic starts in the hospital, and then we actually walk around and talk to all the different teams to kind of talk about their choices and selections because we feel like there's a relationship and it's going to be more sustainable that way. And I get to learn that, we're treating that otitis media because that kid was really pulling on the ear and those sorts of things. Well, okay, I get to hear that. But I also know that somewhere that I can work on in the future, possibly in a different venue. Again, we have the guideline. We go down to even osteomyelitis. You've seen this, but this is kind of another strategy that can be utilized, so a guideline and an empiric guidance. In Kansas City, we developed this prospective audit with feedback program, again, reviewing antibiotics on a daily basis, looking for appropriateness. And I've always said that to do these kind of programs in the inpatient setting, you really kind of have to develop those relationships. And so we really wanted to talk to folks to do this well. And I just wanted to give you a sense of what we've done in pediatrics. A number of people have shown this, that if we utilize the common days of therapy metric that is used in the inpatient setting, and we look at our hospital at the time in Kansas City in this black line versus a lot of other children's hospitals for broad-spectrum drugs, we had a significant decrease while others did not, which averaged to an 18% decline. This is just to say, hey, this works. You know that. It works by just walking in and talking stewardship, and you've likely already seen that. So what about the outpatient setting? Because I think this is what is hard, right? It's not this venue where in the inpatient, they're in the hospital. I know where the providers are. They start it. The next day I can come and talk to them. It's not like you're going to start an antibiotic and then you're going to have the stewardship, quote-unquote, police call you up. Hey, why'd you just start that? Right? It's just not practical or feasible. So how do we even do this? Well, one is what's our use? So I'll step back. And what is our use from a pediatric perspective? Well, we know in pediatric practice is 49 million prescriptions, which is about a fifth of all visits. And as we've already talked about, broad spectrum, you shouldn't be there, right? Most of these are amoxicillin recommendations. In this study, half were for broad spectrum antibiotics, with azithromycin being the most common. Again, most were for respiratory conditions. 23% were for those conditions like URI and bronchitis, which we think you don't need. Now, I'm going to walk through this, and I'm going to do a better job than I've done in the past. I'm going to do this better. So you're looking at this and going, what is this, all these numbers? All right, so this is a study by a gentleman in Seattle. And his whole point and his whole goal was to say, okay, how many prescriptions are inappropriate? In pediatrics, all pediatrics. And so the first thing he did is goes, okay, I'm going to use a large data set, and I'm going to look how many diagnoses were made in these patients, right? So for acute otitis media, there was 12 million. Among these 12 million, 10 million received an antibiotic. right? So you can see in each of these settings, I skip down to bronchitis and URI. These should be 0, right? We assume the closest to 0. And right here we have almost 5 million prescriptions. This is just in pediatrics. I was surprised to see we even had that many diagnosed with bronchitis. Now, that's what we're prescribing. The next thing that I'm going to show here is his attempt of saying, well, what should we be prescribing? Now, how did he go about that? Well, he looked at old studies where we would try to get at the percentage that with like pharyngitis that actually should have group A strep. His thinking and his review of the literature said 20%. You'll find others that would suggest if you bring in adults, it should be more maybe like 35 to 40%. Again, different people looking at different data. But if you add up all of these things about what would be expected, again, this is otitis media taking into account we think many are viruses. Not obviously what the practice usually is. We have about 11 million preventable prescriptions, or 11 million excess prescriptions. This is just in pediatrics. There was another paper published in 1998 that suggested about the same number around the same condition. So we think, obviously, we can do better. And I say we. I mean, this is not easy. There are a lot of pressures on this. There's a lot of things that are competing for these antibiotics. And it's not just your practices, right? You have sometimes urgent cares. My new favorite is we could all pull out our phones right now and get a prescription for otitis media, right? Because we can go to a telehealth site that advertises the fact that they can diagnose and prescribe you antibiotics for otitis media. It's crazy, but that can happen. So I think that's what we're up against. So this paper, and Lori Hicks will describe it much better than I, this one thing. This is a recent from May of 2016 that looked at all, both pediatrics and adults, and says 1 in 3 of our antibiotics prescriptions in the United States are inappropriate. This includes UTIs, skin and soft tissue infections. This is trying to look at everything. But as you saw in children and in adults, 70% are for bronchitis. Now, I know that's a hot topic. Last week, again, speaking with some family docs, they were like, look, man, you don't understand. And that's probably, I don't understand some of these nuances to that diagnosis. And maybe this is semantics. Maybe this is difficult. But I like to think that we know there's some room for improvement somewhere in these illnesses with these patients. So one thing, and I'm not going to go over this for too long, but there are some concepts to think about. The likelihood of an infection, what is the harms versus that benefit? Right? A lot of times we say, hey, we're just going to prescribe because we want them to get better. We don't take into account that maybe the adverse events outweigh actually the benefit, and they're going to get better. And then some strategies for judicious prescribing, as we mentioned already, with like group A strep pharyngitis, using once a day, not doing more than once a day. So this paper kind of goes over this. This is a very busy slide, but one thing I'm going to show you and talk about, in otitis media. Some people are really concerned about if I don't treat that, there are complications that I'm very worried about. Mastoiditis, meningitis. The number needed to treat to prevent one mastoiditis from acute otitis media. Anybody know the number? Anybody have the number? Anybody want to guess a number? 500? Thank you for guessing. 4,000. It's like over 4,000. I mean, it's 4,000. So, like, if you go to England, not that you'll want to do this, but they won't give you antibiotics for otitis media. Right? They'll give you some ear drops for the pain. Now, I'm not suggesting that's where you need to go. I think there's definitely children and patients that need to be treated for their otitis media. But point being is, there are a lot of others that probably don't have to treat. And this is where that delayed prescribing, where you give a family a contingency plan, can be helpful. So again, I think this kind of outlines some of these different facts around these different principles. All right, so in the last few moments, and I appreciate all your patience, let's talk about stewardship strategies in the outpatient world. So I talked about a little bit inpatient strategy we've done in pediatrics. I'm going to talk about both children and adult type stewardship activities. So this is a paper out of the Children's Hospital of Philadelphia. As you know, huge place. They actually have 25 practices throughout the city. And they said, okay, we're going to do a study. We're going to educate everybody, all the practices, and then we're going to randomize these practices into some getting a report where the providers got a report of their antibiotic use. And that antibiotic use was whether they were using broad spectrum or not for respiratory tract infections, right? So essentially, are you using amoxiclav and azithromycin versus amoxicillin for our respiratory tract infections? Now, they accounted for allergy. They threw out kids that had just recently been treated, and they looked at this. All right, so when they did these reports and they gave their reports, they saw this, right? These are the intervention practices. Again, this is physicians seeing their reports. It decreased. Now, this was grant funded, had a lot of impact, but when you take away the grant funding and you don't have the systems in place, this is what happens, right? It goes right back to where it was. So what CHOP has done is they put it into an incentive plan for their prescribers that if they have to be 90% or above for some payment incentives. So different strategy. Not that I'm recommending that, but something that others are doing after this study. This might be my favorite study so far because I think of the simplicity of it. I don't know if anybody's have seen this, but it's called the nudge. So this was done in adult internal medicine practices in LA. And what they did was they had a big commitment letter. And this is like a big commitment letter in some of the rooms with your picture or the prescriber's picture right on it. So they'd walk in, they'd see the picture, and it'd have a blurb about it. And it was all about treatment of respiratory tract infections. Now, I'm going to give you an example, and he made the slide, buddy of mine. He put my ugly mug up here to scare people, I think. But here's the example, and this would be what it would say. And things that say, your health is very important to us. We promise to treat your illness in the best ways possible. We are also dedicated to avoid prescribing antibiotics. Now, again, this is just in the room. They didn't make anybody read it, but it was big enough you could see it. So what did they see? Too much animation, sorry. So again, if you look at the poster condition, they reduced their prescribing by almost 10%. The control condition increased. So they had a 20% reduction just by a poster. A poster. Now, I don't know how sustainable that is, right? I walk through hallways all the time, and I saw a cool poster initially, and then I don't see it anymore. So who knows? But it is simple. And on the CDC Get Smart site, they actually have some of these different poster-like ideas that can be used. So this same group actually did another study. Now, this one, they really pushed the envelope, I think, and it shows it's very interesting. So they took 47 adult practices now, both in Boston and LA. They educated all the practices. Okay, that's always done. And then they randomized these practices into receiving none of these next three that I'll describe, 1, 2, or 3. Okay? Now, here's what they did. First, they did a suggestive alternative, meaning you come in with a URI, they're going to say, hey, why don't you take ibuprofen, Tylenol, maybe some chicken noodle soup, something else you can do instead of antibiotics. The next one's accountable justification, a little more intense. So if you wanted to write an antibiotic or prescribe, amoxicillin for bronchitis, then the medical records made you justify why you were going to do that. And if you didn't put a justification in the medical record, it would say no justification given for this antibiotic. So, yeah, this was out there. Here you go, right in your face. The next one was peer comparison. Similar to what this CHOP study did, but they actually, I think, raised it up a notch. They basically said they gave all prescribers either got one of the following. They either got told they were a top prescriber or you weren't a top prescriber. And they only gave the top prescribers to the top 10%, right? So if you weren't in the top 10%, you got that you were not a top prescriber. You can imagine us as clinicians, we always want to be the top, right? So I think that would drive a lot of things. So what did they see? Not surprisingly, if you had to justify, people are like, I won't use as much if I have to get to that level. And if I compare, the suggested alternatives was not statistically significant in reduction of their antibiotic use. And this is what their inappropriate use. So, again, the take-home for me, now, these are all behavioral economic approaches, right? These are convincing us in other ways that this is how we should do it. So, again, who knows the sustainability? I think that's always the question with behavioral economic approaches. All right, last but not least. Here's the first question I have for you all. And then we can do by show of hands. So, by show of hands, all right, so let me ask the question first. Do you know when a patient, parent, caregiver wants an antibiotic? Raise your hand if it's yes. Yeah, that's so every time I ask this, it's about 90%, 95%. Okay, next question. Do patients, parents, or caregivers specifically ask for antibiotics? How many say yes? Yes, yes. So that's what I find when I ask this. Now, every once in a while I get a few no's. Now, interestingly, there's been studies on this, looking at this kind of communication. One is, how do we interpret, or what are the things that are said that make us interpret whether a parent wants an antibiotic? So the first is this notion of how they say it. So if you talk in symptoms, so if a parent comes in and says, hey, Johnny has runny nose, cough, and fever, that's okay. Like that's symptoms, right? But if they come in and says, hey, Johnny has been playing with Joey down the street who has strep throat, now they're talking diagnosis. Or they say, hey, I think Mary has an ear infection. Or, they actually tell you, like a diagnosis. Obviously, our expectations are going to change in whether we think they want an antibiotic. The other thing is, if we say, I really think this is a virus, and they go, are you sure? Right? We automatically go to, oh, they got to want something, right? That next question has to be, right? And I'm same way. I think the same thing. Now, are we good then? So here are the things that make us think they might want something, but are we good at predicting this? So this is a paper by Rita Mangione-Smith, who's out of Seattle. And when she did this study where she actually asked them, the families after they came out, were you expecting an antibiotic, and had the clinicians say what they think, what they thought the parents were expecting, we were not very good. So we got it right 73% of the time when parents were not expecting an antibiotic, and we only got it 41% of the time when parents were expecting an antibiotic. So we don't pick up on those signs. Now, her study also said that only 1% specifically asked for an antibiotic. Now, I'll tell you, I have a hard time believing that's the true number, because I've been in so many of these rooms with people like yourselves who do this every day of your life, or do it very frequently. So I know it's more than 1%. It's definitely more. I know people. I have people tell me all the time. I've had a friend of mine ask me specifically for azithromycin, a Z-Pack, because he had running purulent nasal discharge. And I'm like, do you know what I do? You can't do that. I mean, seriously? Next day he goes like, oh, I feel so much better. I got a Z-Pack. I'm like, of course you did, right? But that's the reality. But this is, again, I think I will say that I think this is in compelling data. I think we probably aren't as good at predicting, but I also think that people ask more than we think, than we've shown. Now, does that matter? Well, yes, it does. As you can imagine, we are people that want our patients and families to like coming to see us. We have pressures to need them to come back and see us. So if we believe they want an antibiotic, then 62% will get an antibiotic versus only 7% if we don't believe. So again, this is all in communication, that understanding of one another. And again, in this study, the only predictor was really our expectations, or what we perceived that the family wanted. So the same group says, well, one of the things people worry about is the satisfaction, so let's look at how we could talk to our families. Let's see if there's, the way we speak and the way we provide the recommendations would matter. So this notion of positive, negative, and then contingency plans. Positive being, ibuprofen, other sorts of modalities, again, chicken noodle soup, those things, versus negative, you have a virus. You don't need an antibiotic, right? Being very firm. Then contingency plan. Here's a delayed prescribing, or call us back, right? You can, if you're not getting better, those things that allow them to feel like there's somebody there listening. Again, this was in a group of patients that we're commonly seeing, and I've talked about this. What is the risk of antibiotic prescribing for viral ARTIs? If we do positive only, 52% reduction. If we do both, 85% reduction. Using both had the greater probability of highest possible visitor rating. So I only show you this, not that, okay, now you need to go out and start using positive and negative and doing these things. It's to say that communication matters. And you know this, but it really, really matters, and likely matters more than we even realize when it comes to antibiotics. So the summary of this, right? So appropriate prescribing in all settings is important in combating this. We have many different strategies we can use. I think behavioral and communication techniques will be essential. So we're starting a study where we're going to randomize providers into whether they're going to know the expectation of a family wanting an antibiotic versus not. And we're going to provide those providers that get to know the expectation some communication techniques to say, okay, will a communication intervention matter? Right? Will those things help? I don't know. I think we'll see. I will say that because of that, we're going to need a One Health approach. And I think that One Health approach really lends itself to this collaboration. And it's collaborations where I get to come out and talk with you all for two reasons. One, so that hopefully I can help you prescribe better, but also so I can learn, right? I don't know what it's like to prescribe out in this part of the world. I live in what my dad will say a little bit of an ivory tower, which I would fight at first, but he's right. My dad, the family physician, and I need to understand this better. But I think collaboration was shown that in this study by the CDC that at this point in time, if we don't do anything around collaborations among our hospitals and knowing about resistant organisms, we will have a 10% increase of hospital-acquired infections that are associated with CLABSIs and that are resistant infections like MRSA, CREs. But if we'll do something, we'll reduce this. And that reduction will lead to significant amount of death reduction of 37,000 and just infections alone of 619,000. And I think the outpatient prescribing matters in this collaboration. I think all of it matters. Which then leads me to the last story of the night, and then I'll open for questions, is this young lady right here. This is my daughter, Anna. Now, you guys can diagnose this, right? Yeah, right? Orbital cellulitis. So literally, I woke up in the morning, I was getting ready for work, and I hear my wife scream, "Jason!" I said, uh-oh. So I come in, and this is what I find. Now, this is her after getting an IV. I took the picture because she didn't really cry much. She didn't flinch. But, so she gets admitted to the hospital. She has surgery. She gets put on antibiotics. And I didn't worry, right? I'm in infectious diseases. I didn't worry one bit. She got sent home on clindamycin and levofloxacin, by the way, because this was worried about resistant strep pneumo. I was like, oh, my gosh, really? But, you know what? I did, actually, because I still was like, I got to be the dad. Which antibiotic do you think she took better? She took the clindamycin like it was no problem. It was easy. The quinolone, she was like, that stuff's nasty, Dad. I am not taking that. Anyway, so that was... But I bring this story up because what if this was 1921? Like that same story. What if it's 2050 or in this era where we might not have this? So I bring this up because this is what I think of when I come out and speak to you all, and I think we all have these stories. And so I think that's why I really am impressed with what you all are doing, and I look forward to helping any way I can. And with that, I'll open up for any questions. Thank you. Yes, ma'am.
Any strategies on improving vaccinations? We definitely have a population who, probably the more educated population who likes to think that it's smarter not to vaccinate.
Yep. So I think this is one of the interesting parts of our country. The areas that use the least amount of antibiotics are also the areas that are the least likely to vaccinate, right? So this whole notion of vaccine hesitancy. Now, 2 months ago, I would have been running from this question. But I have actually learned a little bit more with some actual presentations. So what are the strategies? Well, I think the strategies are going to have to be continued persistence. Unfortunately, that's what we have. And those strategies, I think, you've seen strategies where people say, hey, I'm just going to exclude you from the practices. I think in a community like this, that's probably a lot harder, and you can't do it. And it's not, and I, as I've looked at the debate on both sides, I don't think that's probably the right thing to do. I think you have to be non-defensive. I think you have to continue to state your points and continue to show the data again and again. Now, the other thing is, in this literature of vaccine hesitancy, they talk about people being in different kind of groups, but they always come back to the fact, if you will continue to have the conversation, you will convert way more than you believe. I think the number's up to 50%, but don't quote me. But again, so my strategy, which you are probably already doing, is don't give up. Continue to be persistent, and you are going to change people. I do think that we have to tell the stories more. I think from a healthcare profession, we have to get our stories out there. Just today, I was writing a story. You know, this is Get Smart Week for antibiotics. And I wrote a story that about my experience of taking care of a child that suffered from a horrible MRSA infection that we couldn't, cure. I think we have to use that on the immunization side, right? I mean, I've seen measles, and I saw these kids measles have strep pneumonia bacteremia. And what is that like? If that was your child, those are the things I think we have to do more and more and more. But I think the biggest take home is you got to keep having those conversations. Sorry, I know I'm not telling you things you don't already know. Rats!
Thank you.
You're welcome. Yes, sir.
Could you elaborate a little bit on the use of quinolones in kids?
Yes. Yeah, it's a great question. So if we step back to, right, where did that come from? Well, the beagle puppy, right? So the beagle puppy study showed that there was cartilage damage in them. Therefore, we are not going to use quinolones. We're going to be a black box warning using in pediatrics. As an antibiotic stewardship person, love it, thank you, right? Because we don't see Cipro or quinolones used, and they would have been used like candy probably because they were easy. So with that as a preamble, we still use them. If you look at there's actually a most recent AAP recommendations that came out from the Committee on Infectious Diseases that will suggest that the use of quinolones in children is acceptable in situations where you could give oral and avoid a use of IV therapy, or that's kind of your only choice. So I have no problem. If it was my own child and they had a Pseudomonas UTI, I would give them a quinolone without hesitation. Now, with that being said, you have to talk to your patients about the black box warnings. And I think we often get confused that there's two black box warnings and they are kind of separate. There's the beagle puppy black box warning that goes to all the pediatric people, but there's the tendon rupture black box warning that goes to everybody. I mean, that includes pediatrics. If you're on long term, you're still at that risk as well, though we know it's the different population. So those are the things. But yeah, I have no problem using it, and we use it often in peds. Yes, sir.
So, we have the science of medicine and we have the art of medicine.
Yes.
We also have the business of medicine. And in the era where patients rate physicians on a satisfaction level based on their perception of what the doctor did, do you think it's real that not giving antibiotics will result in a lower rating for physicians?
I think in this day and age, you would have to throw something at me if I told you that wasn't real, right? I mean, I think there are certain parts of this country that for sure they want something to make them better, and antibiotics have been used. If we look at the history of the use of antibiotics on the outpatient side, even way back in the 1950s when they did combination antibiotics, right? You would get some antibiotic I can't even name plus a decongestant all in one, and they just threw it at you, and this was the FDA policy. So that has been the historical trajectory or what we've been with. So I think in this day and age, I think that that is possible to see that. Now, that's why I think what you guys do is hard, and I think we have to have this as a whole societal approach where you have someone coming in that, as you guys have said, hey, I got people coming and says, I don't want the antibiotic. And then it doesn't become about, I'm going to rate you poorly because I didn't get something, right? Now, if you look at the studies, so I showed a couple of the studies, their ratings always says their rating wasn't dependent upon antibiotics. That's in the studies. I don't know. I mean, I was out in Nebraska, I think near Sioux Falls or somewhere, and I had someone say, hey, look, Leapfrog, I think they use Leapfrog. My administrator evaluates me. I get paid based off of what those recommendations are. I will get poorly rated in that sense. So I think it's real. And I think that's why we'll have to continue to have these conversations, and it'll have to be continued for us to get away from that. We need it. If you go to Netherlands or you go to Finland, right, you go look at their outpatient antibiotic use, it's like nothing. Like they don't use it. They don't want it. I was told that if they get an antibiotic, they feel like they failed. Like that's just a failure. How could this happen? So a different society, different things, but I think that's where we have to get to.
I'm curious, since you're in academia areas, are they doing any research studies that is testing if they give probiotics versus not giving probiotics afterwards, if it decreases the rate of resistant bacteria?
Right. So I don't. No. So I don't know specifically, but I think you touch on something that is another piece of this puzzle. Right? Is like what is happening from a microbiome. Have we heard this microbiome concept that the antibiotics we might be receiving as a young child could impact our microbiome? That could impact obesity. That might be a tough one. Asthma, some of these other conditions, and could we, if we changed our flora, would that matter? I don't know yet. I don't know. I think we will see some studies in the future. I will tell you this, that not on something's different than probiotics, right? We've seen fecal transplants for C. diff. Well, a strategy now being used for really bad resistant gram-negatives, fecal transplants, right? You repopulate your gut with something that doesn't have horribly resistant infections. That's a current trial ongoing at WashU for the adults. And I think the guys up in Seattle have talked about it from the pediatric perspective. So I think we will see those sorts of strategies in the future potentially for some of these chronic patients with resistant infection or resistant organisms. Great. Oh, yes, ma'am. Yes.
So traditionally, we treat acute otitis media with 80 to 90 per kilo, but your guidelines said 50.
Oh, so so it was 45 per dose. So we were doing per dose twice a day. Sorry. Yes. Thank you for clarifying that. But yes, 45 per dose. And then the 50 would have been for Group A strep. You don't have to do up to 80 to 90 for Group A strep. No, thanks for that. That was good. Did you have something?
Okay, I'm an OBGYN.
Oh, yes.
I just have a logistical question.
Yes, ma'am.
How is it that in my 35 years of practicing, I have women who I know have urinary tract infection? I know they do.
Yep.
And it grows out nothing. I swear, I say sometimes you could, culture the toilet seat and it would grow nothing. I've been in Flagstaff for the last 15 years, so I'm new here.
Okay.
I'm not besmirching but my whole career that's been the case. They come in, they have, hematuria, they're miserable. I give them antibiotics and they get better. I know they have bugs in their pee. How come it doesn't grow?
I'd have to say we'd have to look at the microlab in those aspects in that case. There's the other side of this, right? That maybe it really isn't infecting. They were going to get better anyway. I mean, that's what others would say, but that's not fair for me to say because you're seeing these and you know this better than I. But
I had it happen to me personally.
So I think
I was not getting better. I had a fever.
Yeah, this goes back to the diagnostic piece, right?
Yeah.
I mean, I think we have to have better diagnostics. Are the PCR, the more rapid PCR-based tests, are those going to change this for us in the future? Maybe. Can we get it out to our clinics? Can we do that it helps us know up front, even those that are resistant organisms? Because if you have a patient that comes in the emergency department that's trying to die, maybe of urosepsis, and you give them the wrong antibiotic, well, if you're wrong, you're not going to know at this moment in time until 30 hours later that you don't have that. So rapid diagnostics is our way to know up front what we can treat. So that might be part of the solution. But I can't, I don't know. Beyond me.
Well, I always culture it because of exactly what you're talking about. You want to prescribe the right antibiotic.
Yep.
I don't ever just shoot from the hip. I always culture it, but I'm always shocked when it comes back with nothing or mixed vaginal flora. Well,
Right.
come on.
Yes, ma'am.
So in our office, we're having a grand debate between providers of when a child can physically have sinusitis.
Oh yeah, this age group thing.
Yes. So what's your thoughts?
I need to really. I'm gonna start putting that in the slides because this is like the third time I've given this talk. It's like the third time I've gotten that question. Yes. Okay. So if you look at development of sinuses, right? Yeah. Early on, you will have ethmoids. So in theory, right, you could have ethmoid sinusitis, right? So in theory, you could have that. So it's hard to think that a child less than one can really have sinusitis. So I'm sure someone could come up with that. Now, you start developing your maxillaries and frontals, and so by the age of 8 or so, you will have those. I do think in probably toddlerhood, you could get sinusitis as they're developing. But at true age, when you're going to say, I'm going to cut it at 3 and younger, I've never seen any data. And I think in the Ellen Wald study, they even included the younger child. But yeah, I'm not as well prepared for that one. I'm sorry.
Okay.
But it's a good debate.
We have templates and we have an ethmoid and we have maxillary and you divide it by the age.
Yep.
So.
No, it's very true. And so I think, And that's the problem with sinusitis, right? The problem with sinusitis is still a grab bag, right? You have someone come in and you're like, oh man, they just aren't getting better. I got to do something. I feel like I got to do something. Even though 10 days, in theory, still could be at the time of a viral illness that is resolving. So, great question. Sorry I don't have a better answer. Great. All right. Yes, ma'am.
I learned in medical school and residency, never even bother with the back UA. But we see lots, a lot of UAs that are done with kids just in the back. Do you have any
Yeah, so,
for us on that?
yeah, so, from,
Dr. Newland, can you say it louder?
oh, yeah, sorry. So, sorry about that, guys. So the question is about bag UAs. We're seeing a lot of bag UAs in the younger child,
Yeah, especially in the ER.
in the ER. So,
ER doc, sorry.
and kind of where that, any advice from that. So, obviously there is I will say this, in that younger child, obviously in the baby, right, that 0 to 2 months, you and even 0 to a year, I think the cath is the way you have to go. As they get older, I think cathing gets a little bit more invasive to the child. And so I don't get as upset, at a certain point. However, it can make the interpretation more difficult. And I think we have to utilize, if you really, up until probably the age of 2, you're probably thinking cath's going to give you the best specimen. And we're always going to have to realize that. And when we do go after the bag, and if you can't do, if it is a bag, it's going to be problematic. That's the best advice. And so for me, I'm always going to look at, the UA is going to be telling, right? If we look at the guideline, 2 months to 2 years, right? You got to have pyuria in greater than 50,000 or greater than 100,000, no pyuria. And it has to be a single organism and a pathogenic organism. So I think that's where we have to utilize that strategy.
So you would wait for the culture.
Yeah. And many of those times, yes. If it's so compelling, their fever, and you have a pyuria, that's that. But in some of those, I think you can wait. But that's harder. I mean, I think that's a hard part. I think of the diagnostic piece of these infections.